Alex Anderson, student physical therapist at Murphy-Deming College of Health Sciences. And in this video, I'm going to demonstrate and explain advanced manual techniques, mobilizations with movement, PNF patterns, and neurodynamics. Mobilizations with movement is an advanced manual technique that combines passive range of motion with joint mobilizations to address impaired joint mobility or to normalize joint mobility. In this example, I'm going to be demonstrating mobilizations with movement with shoulder elevation. So on the shoulder, the purpose of this advanced manual technique is to center the humeral head with the glenoid fossa in flexion. So we're going to be utilizing a posterior and inferior glide to align the humeral head in the glenoid fossa. To perform this technique, support the patient's arm, their affected arm, under your limb, and palpate to find the humeral head. Once you've found the humeral head, you want to apply a posterior and inferior joint mobilization as you move the arm into scaption or flexion. This advanced manual technique will improve joint mobility or normalize the alignment of a joint during the motion. Neurodynamics refers to a nerve's mobility. If a nerve is entrapped, compressed, or suffers from traction, symptoms such as burning, throbbing, or paresthesias can manifest in a patient. In this section of the video, I'm going to show how to assess for lower limb and upper limb neural tension and how to treat it. To assess for neural tension in the median nerve, you want to put the median nerve on the maximum amount of tension as possible. To do this, you want to start by depressing the scapula, abducting the shoulder to 110 degrees approximately, with the elbow flexed. With the shoulder externally rotated, extend the fingers and the wrist. Slowly extend the patient's elbow and ask them if this motion recreates their symptoms, what symptoms, and where in the range. Does this recreate your symptoms? Tell me when. If this recreates the patient's symptoms, back off with the elbow extension slightly. To assess for neural tension of the radial nerve, it will be a similar process as the median nerve, as you want to put the nerve on max tension as possible. Start by depressing the shoulder girdle, abducting the shoulder to 110 degrees with the forearm pronated. Internally rotate the shoulder and flex the wrist and the fingers by asking the patient to make a fist. Can you make a fist for me? Slowly extend the elbow and watch for patient recreation of symptoms or reporting of recreation of symptoms. Does this recreate your symptoms? If so, tell me where. If this recreates the patient's symptoms, reduce the elbow extension and add a sensitizer of further wrist and finger flexion. To assess for ulnar nerve tension, you want the patient to be placed in a position where they mimic an upside down zero over their eye. To do this, you want to depress the shoulder girdle, abduct the shoulder while flexing the elbow, pronate the forearm, place the wrist and fingers into extension with the shoulder externally rotated. Ask the patient to make a circle with their fingers, with their thumb and their forefinger, and try to rotate that to place it over their eye. If at any point during this motion the symptoms are recreated of the patient, the test is positive. Does this recreate your symptoms? If it does, you can back off with the wrist and finger extension and ask if that recreates the symptoms. The straight leg raise test will assess for neural tension of the lower extremity. In order to perform this test, raise the patient's affected leg after comparing with the uninvolved leg up in the air with the knee fully extended. In the first 0 to 30 degree range, there should be no neural tension. If the patient reports signs and symptoms or recreation of signs and symptoms in the 30 to 70 degree range of hip flexion, that's indicative of neural tension. If this reports symptoms here, slowly reduce the hip flexion angle until the symptoms are no longer present and add in a sensitizer of dorsiflexion or cervical flexion. Can you raise that for me? Okay. To get a better idea of where the tension is coming from, you can favor the tibial nerve by placing the foot into dorsiflexion and eversion, or to favor the peroneal nerve, you can place the foot into plantar flexion and inversion. It's important to remember to reduce the angle of hip flexion where the patient is not feeling signs and symptoms before including these sensitizers in the test. Gliders or sliders are a neurodynamic technique that addresses neural tension. One end of the kinetic chain is mobilized while the other remains the same or is stabilized. In the example of the lower extremity, it's important to find where the neural tension or the entrapment or damaged nerve is occurring. So in this example, a glider or slider would be to dorsiflex the ankle while the knee position and the hip position remains the same. This will address nerve mobility. Another example of this would be at the knee joint, more proximal. You can perform the glider or slider by flexing and extending the knee. With extension of the knee, placing the nerve on more tension, and flexing the knee, reducing the tension or putting the nerve on slack. Flossers are another technique to address neural tension in which both ends of the nerve are mobilized. It's important to remember when performing a flosser that one end should put the nerve on slack while the other end of the kinetic chain should put the nerve on tension. So the example of the lower extremity, if you flex the knee and the hip, the ankle should be dorsiflexed to increase the tension toward the ankle and relieve the tension more proximal. Conversely, if we extend the hip and the knee, we want to plantar flex the ankle to put the nerve on more tension proximally and reduce the tension distally. It's important to remember when prescribing these exercises for patients that they fully understand not to overdo the movements and to also stop before their signs and symptoms reappear. Proprioceptive neuromuscular facilitation, also known as PNF, are diagonal functional movement patterns of the upper and lower extremity that aim to optimize the neuromuscular system through proprioceptive input. There are 4 PNF patterns for the upper extremity and the lower extremity. The first upper extremity PNF pattern is D1 flexion to D1 extension. D1 flexion involves adduction of the shoulder and external rotation of the shoulder. This can be cued as telling the patient to grab their ear and then throw it away as they move into D1 extension with shoulder abduction and internal rotation. The second PNF pattern of the upper extremity is D2 flexion, moving into shoulder abduction and external rotation. This can be cued by telling the patient to imagine pulling a sword from a hilt on their side. D2 extension reverses that diagonal and involves shoulder adduction and internal rotation. The PNF patterns for the lower extremity are D1 and D2 flexion and extension. To perform the D1 flexion pattern of the lower extremity, move the hip into adduction and external rotation, into extension of abduction and internal rotation. For the D2 PNF pattern of the lower extremity, the hip is moved into internal rotation and abduction for flexion, moving into hip adduction and external rotation for extension. Rhythmic initiation is a PNF technique that has the therapist passively take the patient's extremities through the pattern. For this example, I'll be using the D2 upper extremity PNF pattern. Passively take the patient's extremity through the movement with the leading edge. The leading edge of D2 will be on the thumb into flexion and extension. You want to ask the patient to watch the movement as you perform it. This will help ingrain the motor pattern in their system for later active performance of the pattern. Repeated contraction is a PNF pattern progression from rhythmic initiation in which the patient actively performs the diagonal movement pattern. For this example, we'll be using the D2 upper extremity movement pattern again. So with this, you want to again emphasize the leading edge, but have the patient actively perform the movement with you just guiding and cueing the movement. So Matt, if you can, raise your arm up into D2 flexion, good. Now back down to extension. You want to emphasize the rotational component first as it's moved. You can do this for reps, and we'll emphasize the movement pattern with the patient actively performing it. Slow reversal is a PNF pattern technique that introduces resistance into the aforementioned PNF patterns. So again, with the example of D2 flexion and extension, the patient can now actively perform the movement. So the therapist is going to provide resistance both directions going into both portions of the movement. So in this example, we're going to instruct the patient to enter the rotational component of the movement first as I provide resistance as he moves against it. It's important to remember to keep a constant tension throughout the pattern at the same speed as this is an isotonic contraction. Rhythmic stabilization is another PNF technique that can be used to increase dynamic stability in the PNF pattern at a specific range of motion. Going back to our example of D2 flexion and extension, the patient will be asked to move through the range of motion until the therapist assesses that there is some dynamic instability involved in that specific range. From here, you can initiate the rhythmic stabilization through many forms. One would be to introduce perturbations to the limb in this specific range of motion of 90 degrees. One way to progress this would be to move from proximal to distal, to increase the rate or the speed at which perturbations are introduced, or do it randomly instead of in a fixed pattern. This is going to introduce the feedback mechanism of dynamic stability. Moving through the range of motion, we can also progress by doing this in a functional portion of the range of motion, again using the same progression pattern of proximal to distal, faster to slower, random, block to random. And finally, in the overhead position, we can do the same thing and introduce the progression patterns into that to create that dynamic stability and improve on that to increase function. Hold, contract, relax is a PNF technique that uses the active contraction of an agonist muscle to increase its passive stretch. So for this example, we're going to be targeting the hamstrings for a stretch. So bring the patient into a stretch to where you feel some restriction, and then ask them to contract the muscle. So in this example of the hamstring, Matt, could you push your foot down into my shoulder, please? You want to make sure that you have a stable surface for the patient to isometrically contract against you. Allow them to hold that for about 5 to 10 seconds. Okay, you can now relax. And you'll be able to passively stretch the muscle targeted through a longer range of motion. And you can repeat. So Matt, press down against my shoulder for 5 to 10 seconds. Okay, you can relax. And then move the muscle through its newly gained range of motion.